Tipaza Clinic, Bandung. She is taking part in Department of Dermatology and Venerology, Faculty of Medicine, Universitas Pajajaran, Dr. Hasan Sadikin Hospital, Bandung. She is actively on clinical research for many dermatological findings and has published many articles in clinical dermatology. She has spoken for the 24th Regional Congress of Dermatology in Bangkok, Thailand, and the 24th World Congress of Dermatology in Milan, Italy. So without further ado, I will invite Dr. Reiva to take the stage.
Hello.
Hi, Dr. Reiva.
Hi. Hello, Amelia. Hello, everyone. Good night, and thank you very much for this meeting. This is an honor for me to join in this beautiful meeting to share my experience in PicoGenesis laser. Okay, so now it's time for me to speak in 20 minutes, right, Amel? Okay, thank you. First of all, now here in Bandung, Indonesia, it's actually at night, but I have a very beautiful full background here. It's afternoon, but now, I mean, it's a virtual background, you know, because we are here at 7 p.m. here. Okay, dear ladies and gentlemen, so for tonight, I will just share my experience in using this PicoGenesis laser for almost 1.5 years. And then I don't have many theory about this. The expert Dr.Sky Wong will talk about this after me. But I want to share my experience, which is some is a very excellent result, and maybe one or two not very good. Okay, and then I want to discuss more about detail about it. Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good night, everyone. This is just a picture of me and my patient. All of the pictures in this presentation have got permission for the patient, and and as well as the permission of myself here, of course. This is a journey with the PICOSECOnd laser, satisfied and unsatisfied cases. Okay, the journey began when I have a plan. So it's just a little bit a short story. When I built a clinic with my several friends, dermatologists, about 11 years ago. So this is a small clinic in the house, and then we were growing up, and then I have a dream to make just a center of the laser clinic in Bandung, Indonesia. Maybe some of you that have been coming to Indonesia after this pandemic, you should go to Bandung and then see this beautiful city around the mountain here. And there's one clinic in the center of the city, Tipaza name. And this is the clinic right now. And there's I have a dream that I want to make. I want to have a very very good. I mean, the modernness of the laser is the Pickle Laser. So, but it costs like it has a expensive. Yeah, you know, the cost is not low; it's very high cost. So, I want to know about the benefit and the cost of this laser. So, based on my IT base, for my computer base in my clinic. I have done a laser for about 100 times in this year, but for one patient is of course more than one patient. I don't expect that I have a lot of experience in this laser, but yeah, almost every day I made a Pickle Laser in my clinic. Yeah, it's only for me, not for other doctors in my clinic. Okay, so the experience of using Pickle Laser, I conclude for 3 results, which are very good, and maybe moderate. I have a very good experience, excellent experience for nevus of Ota, also as well as freckles and rejuvenation. And for tattoo, sorry, it's wrong picture. For the tattoo and HPI or hyperpigmentation post-inflammation, it's more a good result, but not too good, I think. But it's quite good. But the moderate or maybe less unsatisfied result is for the hoary nevus, melasma, and scar. Well, this man should be in the second row. Okay. Now, this is my first experience. My first case that I want to share with you all here. This is a case of a girl, maybe not a girl, but about 20 years old lady here. Nevus of Ota before treatment here, and then here the second laser. It's more erythema redness here and here, and this is very good result after 4th session. The third session interval just only 1 month, just only 1 month, and from the third and the fourth session it's about 6 months, and it's very good result here. Okay, we see here. And then why at the second laser it's very erythema, because I enhanced the energy, I increased the energy maybe twice. And then you can see here that the hypopigmentation here in this patient, but the lesion, the blood or the hyperpigmentation is maybe like disappear here. Okay, still hypopigmentation here, and also maybe a blackish here. Okay, now we can see here, and then after the second session, okay, so very aggressive, I think. I want to try, because this is the suggestion for the Asian skin, and I want to try deeper on also the more aggressive, but we have a hypopigmentation here, but other, I think it's very good here. You can see, you can see here, and it almost disappear only at the lower palpebra. Okay. Here and also here and also here. So these are the parameters of the patient's laser. Spot size we use 4, and the repetition. Now, at the second, I increase the repetition, and also here, okay, the fluence. Okay, here it's around about 2 until 2.8, or the maximum is 3. Okay, so the lesson from this patient that for the nevus Ota, it's very good result. If we choose the right fluence, I mean about 3 maximum, or maybe 2.5 joules per centimeter square, but not change the repetition rate. Because after I increase the repetition rate, I have a like a desquamation, also erosion and purpura, I think, in this patient. So after that, it's very good result, but don't too frequent. I mean, maybe about 3 months or maybe 6 months is better. If then we do it only just interval for 1 month, because you know that we have to make other immunocompetent cells, like Langerhans cells, to take the debris of the melanin here that have reduced by the laser. So in this patient is very satisfied for the result. She's very shy and very sad every day, but now she's very happy and she's working right now. I think it's a very good result to increase the quality of life of the patient. So for the first case, for the nevus Ota, I recommend to use the PICOSECOND laser. Okay, and then the second case about multicolor tattoos. In Indonesia, there's not a lot of people that have tattoos, not like at the Western country, yeah, because of the restriction by religion and also the culture. But if someone that have tattoos and want to remove it, it's very difficult. Yeah, usually they use the alcoholic or acid to remove it, and it makes scar and kill it, something like that. And this patient, he has 4 tattoos here at left upper arm, and then lower arm, right wrist, and left wrist. And it's not very good tattoos. I don't know what's the shape of this. Maybe the diamond with some colors. Yeah. Okay. And then in this tattoo, we have a green, red, yellow color at the left wrist. And then we made 4 sessions of the laser before treatment here, and then we use 2 nanometers, and also the 1064 nanometers picosecond here. At the first, and this one, the second, you can see this slightly disappear also here, and almost not seen in here at the 4th session. Sorry, it's not a really good quality of the picture. So we can see here the comparison of the tattoo. Okay, almost disappear. Okay, and in here. But this patient, unfortunately, he moved to another city, so he cannot come back here to Bandung because of this pandemic. But after this pandemic, he will control to my clinic, and we will see the last tattoo of this patient. So I think it's a moderate, yeah, but it's very good for the colors. The red, the green, yellow, it's almost disappear here, and also the not too dense or not too thick of the ink, the black ink here, yeah, it almost disappear. But the very thick, very super black color of the tattoo, it's quite difficult. But I think if he continue the session, or maybe at 6 sessions or more, it will get a very good result. Okay, here me with this enlightened laser. It's big. Okay, so the parameters here for the first and second and the third and fourth session, the fluence is different. I think. Okay, so it's for 532. Okay, it's only not 532 because I think it's like he has a erosion or bulle at the second session. Yeah, the bulle, maybe because of it's very high, it's very big fluence, I think. Yeah, for the first time. Okay, and then this one, the fluence, it's almost average like this. Same the repetition rates, both size, and for the color tattoo, yeah, we know it's in the at the epidermis, and the back tattoos at the dermis. Okay. So this is the third case. Can you guess what's the diagnosis of this patient? Because there's maybe hundreds, or maybe 1,000, not 1,000, but hundreds of tiny little spots of the patient. Okay, here, and also at the lips, tongue, and the palatum too. Okay, see here, very spreading, eruptive. Okay, eruptive, yeah, it's only in 1 month. It has a lot of these thousands and hundreds of the black spots here. Okay. So, you can guess the diagnosis of this patient. He has eruptive lentiginosis. Yeah, and we made laboratory examination. There's all in normal limit. So we know the pathogenesis of this disease is not unknown. Yeah, but sometimes that don't have a very good result after several treatments. modalities of treatment. Okay, so we do the spectrophotometer for this patient here, at the right cheek, left cheek here. So also there was a lamp examination to know where's the pigmentation lie on. Yeah, it's epidermal pigmentation. Okay. So this is the patient after just minutes after we do the laser here. This is 532. Okay, it's purpuric and also maybe several lesion of the urticaria. Okay, it's temporary. Okay, now this is the 3 weeks post laser. The patient is working outside the Java Island. It's he only come to Bandung, his hometown, maybe about one two times in a year. So we can he sent his picture via WhatsApp application. So we see here very good result, I think. Yeah, very good result at the face. But at the body, at the trunk, we still have this crusted, the several crust, because it's only 3 weeks. Yeah, this is the day first and 3 weeks post laser after the crust is disappear. So this patient is very happy for the condition of his face. He maybe not really care about the body because covered by the cloth, but he's satisfied with this result. And after pandemic, maybe he will come back to take the second session of the laser. Okay, so this is my unsuccessful case. The 3 cases, that's my successful case that me as a doctor and also the patient are happy with the result. But this one is maybe not unsuccessful cases, maybe not yet, or less unsuccessful cases. This is a PIH at the melasma case. So this patient has a melasma. So I do the, like a tretinoid and hydroquinone for several months, but not a very good result. Because we all know that melasma is very difficult to treat and also have to be very long treatment. Yeah. Okay, this patient want to try the Pickle Laser. So I did the 532 for the epidermal melasma and 1064 for the dermal melasma. But HPI or PHI post-inflammatory hyperpigmentation after all of the lesion, it's as well as epidermal or dermal melanin. So HPI, PIH is not good. I think maybe I want to consult with Dr.Sky Wong and other doctors here. I saw that Professor Farah Wong here in the so we can discuss what's the best parameter or what's the best modality to treat the melasma. Okay, and then it's not, I think it's quite good, but not really good for the very deep scar like this. This is the second case that not really good or moderate result. This is very deep scar. We know to treat scar is it's many modalities to treat scar. I want to try only single treatment with the MRI lens, for this PicoGenesis. So I try for the third session. So we see here, okay, maybe I can see, okay, this better. We can see here is I speak scar, getting better. I speak scar. Okay, so also the tightening and smooth the surface of this patient is getting better too, but not like a deeper scar, like a box scar or rolling scar. We know it's not the modality is not for the laser, but subcision maybe, and also the microneedle. But I want to try all of the kind of the scar that treated by this MRI lens for PicoGenesis. Yeah, this is after the third treatment. Yeah, I think it's quite good, but maybe if he continue for the maybe 5 or 10 times laser only, not with other modalities, it's will become good. Yeah, the result is better than this. Okay, so that's my short presentation that I successfully and maybe not unsuccessful, but maybe moderate result of this PicoGenesis laser. So that's not only me in this clinic. I and other 8 doctors, dermatologists here in Tifaza, and also we have a plastic surgeon here, and then dentist, and also the clinical nutritionists here. So we are like a comprehensive aesthetic and also for the dermatology disease in Bandung, Indonesia. Okay, thank you very much. That's my short experience to share with you all about my experience using the PicoGenesis laser for maybe 1.5 years. Thank you, Amel. Good night, everyone. Thank you very much for these opportunities.
Thank you, Dr. Reiva, for a very fruitful sharing and so many cases that might be discussed later with Dr.Sky Wong. But first, we will continue with Dr.Sky Wong, our second speaker. Hello.
Nice to meet you. And thank you for the wonderful presentation of Dr. Reiva. And I think that is really cases that we can really learn from you. And for me, I will share some of my experience in Hong Kong. Is still also the Asian skin type. And so maybe we save some time and just let the ball rolling now, okay? So let's get the presentation starts now, and then we can answer more questions in the later time.
Thank you.
Okay, let me share my screens first. Wait a minute. Share screen. Okay, I think we can see the presentation, and let's see if the sound quality is good. Okay.
Okay.
Okay. Okay, so I
think your audio is still a little bit small.
It's just okay. Wait a minute. Let me change a little bit. Okay. Let me turn it on for louder sound.
Okay.
Sorry that I can share. Hello. I'm Dr.Sky Wong, and this is my... And we will talk about it.
Have you tried share the sound when you're share your screen?
And we will talk about whether or not it is only a trend or is actually a necessity of developing the picosecond laser. And we'll actually talk about the technology about it, and then we'll talk about the clinical application and pearls. Laser is really a global demand and trend. It's up to 40% of US population having the pigmentary conditions that requires laser treatment, and the situation is even higher for the Asian population, up up to 70%. And there is a lot of laser procedure done, is up to 14 million of the laser procedure performed in the Asia, and 71% of them requires a texture and tone improvement, which can be brought about by laser. So laser treatment is the main trend of aesthetics. And that's why we need to develop a good system for laser. And that is the reasons for the evolution of picosecond laser. And picosecond laser itself will have a lot of beautiful mechanism inside. And just to name a few important ones are being the line, multiple wavelengths, LIOB, and the plasma. And that is the trend of the future laser. So what are the properties of the picosecond laser? There are four main new properties. First of all, it is a line procedure. Because picosecond laser is a photomechanical laser, it generates way much less heat, so it irritates your skin way much less. And because it is highly specific and very selective with high effectiveness, so it has a very wide therapeutic margin. And that's how it makes the laser less irritating and more effective. And this is the short form for line. So picosecond laser is a line procedure. Secondly, multiple wavelengths. With the newer technology, we can create newer crystals, and some of the technology like the OPO, we can create a lot of different wavelengths, including 670, apart from the traditional 532 and 1064. This will allow us to cover a wider range of the target chromophores. And then thirdly is the LIOB. And this will be a very unique property in generating the collagen spot formation in your skin, and also results in a rejuvenation. Fourthly, very importantly, is that the focusing lens, we can also create not only the LIOB, but also the plasma. The plasma formation will result in controlled ablation of your surface of the skin and resulting in resurfacing, regenerations. So these are the very important property of picosecond laser, and if we can use it in a more dexterous way, then you can achieve a lot of therapeutic goals. And photomechanical effect is when the laser beam is struck onto the target, it will cause central compression and peripheral expansion, resulting in shearing force to break down the target chromophore particles. And because of this, it is much less heat generations and results in a less irritative, more effective line procedure. And this kind of the irritated skin resulting in the mixture of the hypopigmentation marble rocks appearance is much less likely. Okay, so secondly is the multiple wavelength. You know, wavelengths, different chromophore will be targeted, and with 532, you're targeting the melanin very well, but the penetration is for a superficial layer, so it tackles a very superficial layer very well. And 1064 is for deeper generation, is very good for the darker skin type because it bypasses the functional superficial epidermal melanin, so that it will generate much less complication like burn, hypo, or hyperpigmentation, which is given rise by 532. And it is a newer generation of 670 that will have a longer penetration, but still superficial to target the pathological superficial pigmentary disorder while bypassing the functional epidermal melanin layer. So it will result in a very good therapeutic result without the complications brought about by the 532. And there are lots of people asking me, what is the LROB phenomenon in the picosecond laser. And actually, LROB together with the plasma ablation comes together. But the LROB is the laser-induced optical breakdown, which is a unique property in which the picosecond laser, already high-powered laser, is being focused to a more even intense spot of energy concentration, in which it will denature the molecule to form the electron cloud, results in a vacuum formation. This is a vacuum phenomenon. And then these holes will be formed and attract the fibroblasts who goes in and lay down the collagens. And as a result of this, the LROB will induce the new collagenesis. At the same time, it's virtually like a virtual needle that is plugged into the skin and inject the collagens in the atrophic dermal skin layer. And this is actually similar to the things that we do for the subcisions and injection hyaluronic acid at the end of the procedure. So this is what I call this the LROB subcision. It is only different from the real needle subcisions in a way that we don't need any needle, and we are injecting the collagens of the patients themselves, okay? And secondly, for plasma abrasions is formed as a the nature of the electron cloud over the superficial part of the skin, and it is arranged in a fractionals and arrayed manner, so that it is the ablation under a controlled pattern, and then it is a resurfacing rejuvenation procedure. Therefore, with the MLA focusing lens of picosecond laser, we can have both the new collagenesis, LROB subcision effect, together with the resurfacing effect over the skin. So it is a double effect for the skin rejuvenation, especially good for the pores, fine wrinkles, and the atrophic scars. Here is the illustration of the non-ablative and ablative traditional fractional laser, in which the whole column of the skin is being irradiated, and so the installation is more full thickness. Well, for the picosecond laser, it is having the LROB in the deeper layer of the skin, while the superficial part is having the plasma ablations, so that the rejuvenation is new collagenesis at the bottom, and the superficial surface is a resurfacing, and so the tissues and the skin in between the two will be entirely untouched. Therefore, the recovery time is way much faster than traditional whole column irradiation. And together with the laser toning, we'll have the improvement of the resurfacing, new collagenesis, and the pigment improvement. And this is the wonderful outcome of rejuvenation that we ever want. And here is the lower fluence MLA focusing lens treatments, in which you can see that there is very gentle and there is no reactions after treatment, and the collagen spot formation will be finer. It is for the fine pores and also fine wrinkle regenerations, rejuvenations, and the recovery time is minimal. And if it's for the more severe atrophic scar, then we can tune up the energy to result in more LROB subcision energy and the plasma formations, and then it will result in more significant subcutaneous bleeding petechial formation, but the recovery is usually fast, within 5 to 7 days. When we talk about the fractional focusing lens, we have to know about the wavelength. In simplicity, it means the effective focusing area that is exhibited as the red circle area. The waist area is a highly concentrated energy area of the focusing lens for the picosecond laser. The longer the range, the better will be the result. And from this diagram, it shows that the MLA relay range is longer because the MLA focusing lens is having a narrower angles of focusing. And then if it is for the HLE holographic one, it is rather obtuse, so the range is shorter, so the effective treatment length of the MLA is longer than the HLE. This is the illustrations for the MLA, in which that the focusing angle is narrow. Therefore, the relay length is long, and then the effective treatment length is longer. And it is very important because and also the skin is not even. Therefore, when you're doing the toning using the MLA along the skin of the face or any parts of your body, will be a little bit ups and downs. If the effective treatment length is longer, so that it ensure all the time your effective treatment energy is having your skin inside that range. But if it is for a holographic HLE lens, the focusing angle is rather obtuse, and therefore the effective treatment zone is very sensitive to a handpiece position. A little bit change in the depth or the distance of the handpiece to your face skin will be making the effective treatment zone out of your skin, and then the treatment is less effective and good and optimized. We have all the theory, and then we can apply the technology and the new trends of the picosecond laser in different clinical applications. First of all, it is the shoulder lesions and freckles, which is very common, but in the past, in the years of the Q switch, still there is lots of complications and the resolution is incomplete. By using the picosecond laser, and Negishi et al. Has investigated into 20 females and found that even though the 532 wavelengths of PIH rate is decreased from the traditional Q switch era of 10% into only 4.65%, and the improvement is approaching 80% of satisfaction. And moreover, you can see that on the B diagram, this is picosecond laser, it shows much less epidermal-dermal junction insultation when compared to the A diagram. This is as a result of the irradiation of Q-switch laser. And from my team of work, we have investigated on 30 patients. We found that they have 80% of excellence improvement, and by using 670 nanometer wavelengths, the pH range is even pushed to a lower limit from 7.65 for the 532 by Negishi to 3.3% by using the 670. And so that the conclusion is, with the picosecond laser, with the adequate wavelengths, we will have much less PIH and complication and better resolution. And here are the cases that we use the 532 after 2 times the treatment, the improvement is excellent. And by using 670 picosecond laser after 1 time the treatment, the improvement it can be up to 50 to 70%, which is amazing. And after 2 times the treatment, the improvement is up to 90%. And this is another 3D diagram showing the before and after treatments of 2 times of 670 picosecond laser. You can see more than 90% of the freckles is being removed. And for the larger lesions like the soil antigen with some of the skin structure alternations, the result is also good. After one time the treatment, you can see that the improvement is amazing with a little bit of randoms behind, and then after 2 times the treatment, you can see that the improvement is almost 90%. For the closer look, you can see that the improvement of the pigmentation is very amazing. And for the anom of Horace macule, anom is affecting quite a number of our population, usually affecting the middle-aged woman, which is a very deep-seated spindles, abnormal melanocytes inside our skin that is hyperactive, producing lots of melanin, causing the pigmentary problems. And what we need to do is use a very high energy for numerous sessions, but there is lots of complications like bleeding, PIH, hypopigmentation, crusting, infection, etc. But the results can be incomplete. This is the literature review showing that we really need to use high energy, a lot of time treatment to result in partial improvement only. And then with the PicoSecond laser, we use way much less energy, only half of the original Q-switch laser energy, and then results in more effective outcomes and less complications. For my team, we have investigated case series and published in JAMA Dermatology. We found that the less fluence that we use by using the PicoSecond laser is even more efficient when compared to Q-switch. We have a less downtime and complications, less number of time of treatments required, and use of the MLA may also help with some special situations alone. And these are the outcomes that this is very amazing. And for a closer look, after only 5 times of treatment, you can see the improvement is excellent. And for the more severe anom, Horace macule, the improvement can be clinically remitted. And even for the low contrast anom, the improvement is also good with the assistance of MLA. And it is even better for use of 670 in terms of the standard ratio, more deeper penetrations, and my experience is very satisfactory for using the combination of 670 and 1064. In this diagram, you can see that combination 532 and 1064 improvement is good, but it's even better with the combination of 670. And this is the outcome as well. This is a male. You can see the improvement of the cheek is very excellent. Here is often this is a similar conditions of the anom Horace macule, but it is congenital condition. This is requiring high fluence limit treatment, a higher rate of complication, but still incomplete response. Then we use PicoSecond laser, more effective by using even lower energy. You can see that for this gentleman is already received 9 times of traditional Q-switch laser. The improvement is plateau, no more progression. But after a few times of PicoSecond laser, you can see the improvement is excellent. He even changes his hairstyle not to cover his face anymore because he has no more pigment to cover. And then for the treatment, after 1 time, the improvement can be around about 10%. And then after 4 times of treatment, you can see that the improvement is more than 70%. And here is the 2D before and after photo showing that there is amazing improvement of the nevus aorta in this patient. And note that for the around eye area in the past, we dare not to use a Q-switch to use high energy laser to blast onto the eyelid because it's so delicate skin and easy to get insultation to the eyeball. But together with the PicoSecond laser, a gentle and line procedure, we are now able to use a much lower energy, gentler settings, but higher effective line procedure on this kind of delicate eyelid skin. So we don't ever encounter a panda sign anymore, and we can treat the whole face skin together with the eyelid skin together. And this is the future development of better application of PicoSecond laser now and in the future. Melasma, a very big headache condition of us, complicated conditions affecting 40% of Oriental females at the early age of 42 years of year, and it is multifactorial, difficult to treat if there is any wrong in any component of your treatment that will result in rebounds and PRH. And so that we need to make the first step correct is to use non-irritative line procedure, and that is the PicoSecond laser, okay? And remind you that it is not only the PicoSecond laser that treats the melasma, but also we need to use the stabilization method, repair the skin architecture, treat the vasculopathy, etc., reduce the inflammation in order to treat the melasma satisfactorily. Therefore, we may also need to use the whitening cream, melanin stabilizers, transamines, isotretinoin, etc. And we also need to classify different types of melasma so that we can have the respective approach correctly in order to have the condition managed appropriately. And there are, for me, classifying the melasma into 6 different categories. Geographical, is isolated island, and then is melasmic nevi, mixed melasma, melting tight river melasma usually occurs in the periorbital area, molted hyperhypo pigmentation dyschromic melasma. And all of this classification is very complicated, so I need to present this in another lecture, but it is out of the scope of this presentation for the trend of PicoGenesis. But the take-home message is that we need to classify the melasma into correct category before we act. And also, it is important to use PicoGenesis making use of its line procedure. And we'll give you the lecture about how to classify the different approaches for melasma later, if you're interested. Stay tuned and connected to me. Then this is the geographical melasma. You can see the improvement is excellent with the Pickle stable epidermal melasma. The 532 and 670, after one-time treatment, you can see improvement is excellent. And it is the isolated islands that we use high-power 1064 for destructive approach. And then this is the melasmic nevi using similar approach as the isolated islands. Then there's a complicated mixed melasma that we need to use combination of different wavelengths like 532, 670, 1064 of different energy and different approaches using the tonings and also the spot treatments. And then you have to realize and keep an eye on the skin if they are having the vasculopathy. If there is any so, then we need to use the vascular laser in order to pre-optimize the skin before we go for the picosecond laser to blast out away the melasma. And this can be achieved by the double tonings, by in the way that it blasts away the pigmentary problem, melanin problem of melasma, and then at the same time we use the vascular laser, be it the quasi-lumpos or lumpos 532 or 1064, in order to eliminate the vasculopathic components of the melasma. MRA. And other very important technology of picosecond laser that I've explained mechanism sessions earlier in this presentation. With that, minor pores and fine wrinkles can be reduced very effectively by using the lower energy of MLA, and this is the example. This is another example. We can notice that it's not only the pore improvement, fine wrinkle improvement, but also the pigmentary problems is also improving, okay? And this is improvement of the tone and general texture of the skin. And for the more severe conditions like the patient having ice break, box scar, road edge deep atrophic scar, we tune up the energy of the MLA, and that will result in a double effect. Remember, this is the superficial resurfacing by the plasma ablation, and also the underneath thermal RLB substitution and neurogenesis, and these two kinds of mechanism will help with the atrophic scar improvement very usefully, okay, effectively. And this is another case of the atrophic scar of the temporal area of this patient. You can see that the temporal area is becoming way much more smooth after the MLA treatment. And even for the more larger atrophic scar, this is the patient who have the Chinese medicine herbal burning therapy at childhood. And you can see that the atrophic scar is very much indentated, but we, together with the MLA and the picosecond laser treatment, you can see that the improvement is quite amazing, okay? So as a conclusion, picosecond laser is not just a trend, but it is a future necessity that we need to develop. And a good picosecond laser console is important to provide the quality LIME line procedure and provide you adequate wavelength selection for treatment of different skin problems, and to provide you a effective RLB and laser substitution effect, and also fractional plasma for the resurfacing. And benign pigmentary disorders, as is discussed before earlier in this presentation, is common, and the picosecond laser is very important solution component. And classification of the benign pigmentary disorder is very important, so that you can adjust your picosecond laser console to different settings to adopt different protocol for the effective treatment. And this is even more important for melasma classification, because one minor step, this is wrong, then you screw up the whole thing. And if you would like to have more deep insights on the picosecond laser treatment for the various benign pigmentary disorders, you can also look into my articles just published in 2019. And thanks for the contributions from the friends around the world, from Malaysia, Thailand, Hong Kong, Singapore, Indonesia, Australia, Taiwan, Korea, UK, the USA, and also Serbia. We have concentrate and also crystallize all the wisdoms and knowledge into this book. We talk about lots of the pigmentary management together with the energy-based device, injectables, and miscellaneous topics, including the cosmetic surgery in this textbook, which is a contemporary, concise, important reference textbook for you, for everyone. And so stay tuned, it's going to be published soon by the Cambridge Scholar Publisher. And we will also provide a wide range of the education through different platforms, including the AIMER with my center, LSU Medical, and the AAM, Hong Kong U Space, or Pretoria University, etc., so that we can share more knowledge and skills in the aesthetic medicine through different webinars, workshops, etc. And if you would like to know more details or would like to ask me more questions about today's presentation, you can connect to me through the Facebook, IG, WeChat, as well as the email. Thank you very much for your attention and time.
So thank you very much, Dr.Sky Wong, for your presentation. It's a very insightful presentation, and I'm pretty sure all of us will learn a lot from your experiences. And we are also waiting for your textbook.
Yeah.
Publishing soon.
It's by all the friends in the region, including Professor Wong, Professor Rashima, Lim Tin Song, lots of friends around the world. I hope that is really a contribution to the field.
Yes, we are really looking forward to that. So we are continuing our session to the Q&A session. So I will invite Dr. Reiva to join with us also. Okay, so we will answer the questions in the Q&A box first. So first question is for Dr. Reiva. Is it need to stop our regimen before and after doing the Pickle Laser, and for how long? And for what kind of topical cream to support for the laser result?
Okay, thank you, Amel. Before that very nice presentation, Dr. Wong. I learned a lot from your presentation. Now, to answer this question about the stop regimen before the doing Pickle Laser, yes, of course, we have to stop the tretinoin cream for that we use for the night cream, maybe about minimum 2 days, and then after that, depend of what kind of the treatment that we do. Is it like ablative, like for scar, and also for the maybe the 532 that have the result like a crust. So we can use the antibiotic cream, and also the like a serum that have growth factors inside there, and also for we have to avoid the sunshine, sun ray, and maybe we can apply the sunscreen for that.
Okay, and what is the kind of topical cream that you use to support for the laser treatment? Maybe the post-care treatment after the laser.
Like the antibiotic cream for the ablative laser, like a scar treatment, and also for the crust result, crust result like a 532. It usually have a crust result after that, like a freckles and pigmentation and lentigo. So we can use the antibiotic cream, and also or ointment. Yeah, it's better to reduce the scar. Okay, and then maybe the growth factor and something like that to increase the result of the laser treatment.
Okay, thank you, Dr. Reiva. Dr. Sky, do you have any addition for the post-care treatment after picosecond laser?
Yeah, well, actually, I totally agree with the suggestion that Dr. has mentioned. And I think that for the pre and post care is very important, because for preparations of the skin, if we prepare very well, then the treatment is even better after the same setting. So I agree, we can use the tretinoin cream. We can also use Clipman solutions. We can also use the lots of whitening cream. There is lots of new emergency of the agents that includes the alpha-albutine, kojic acid. We will also use the lecorize or combination of all. And very importantly for tretinoin cream, it also, or adapalene, we can actually strengthen the skin and make it have a better repairing power. But of course, just like Dr. Reiva said, we need to stop the tretinoin cream 2 to 3 days before the treatment is safer. Okay, but it really depends on the skin quality of the patient and the response of the patient's skin to a particular concentration of tretinoin. So we need to be determined by the doctors, by the dermatologists. Well, for the post-care, a lot of laser after the treatments, there will be some erythema. And there is a concept called erythema index, which is actually discussed 20 years ago. And it correlates the redness with the PIH. So if we do the laser, it has the redness, then we will probably have a higher chance of PIH, although it is not a 100% correlation. But if we can actually decrease the amount of the redness, it is better. So the first thing to do is choose a line procedure, and that is the gentle pickle laser. And certainly, even though after PicoSecond laser, there are some of the patient will still have the erythematous redness reaction. At that time, we may need to give some very good moisturization, and also sometimes we may need to give a little bit of low-dose steroid in order to decrease the amount of redness and prevent the severity of PIH if there are any. Of course, we need to put on very good sunscreening in order to stabilize the delicate skin in the irritable stage after the PicoSecond laser or all sorts of laser. And these are the pre and post advices in general.
Right, thank you very much. So it's important not only on the session, but also the pre-treatment and the post-treatment care also. So we will continue to the next session. I think it's for you, Dr. Sky Wong. Based on Dr. Reiva's presentation, we cannot see much improvement for PIH with PicoSecond laser. But based on your experience, have you ever treated PIH with PicoSecond laser only? Or should we combine with other modalities as well?
I see. Well, actually, the Asian skin is a little bit tricky because we are quite sensitive and reactive to all sorts of irritation. It's not only the laser. Therefore, if you actually are doing the PIH, but during the treatment you are using a little bit higher energy, that may actually induce the erythema and inflammation. And you know, PIH, the name is post-inflammatory hyperpigmentation. If you would like to treat the PIH, but you induce the inflammation, that will be a problem. And secondly, even though the skin of us, Asia, and actually very common in Hong Kong people, that even though you don't induce any inflammation, there will be a short period of time called the Whipple response of our skin. It means that after the laser, no inflammation, but still there is some smoky base of pigmentation deposition of the skin. And in this way, it means that the patient's skin itself is inherited maybe from her mother or father, that they are very light unstable. And in this way, we need to really tune down a little bit of our laser energy, or we use other ways of energy device to treat the PIH. For example, there is an article from Professor Rashima. We may use 9027 thallium fractional laser to help with this kind of PIH and melasma conditions. So it is really a tricky point for treating the Asian skin. Therefore, we need to use different methods. I say that 70% of the picosecond or 70% of the PIH can actually tackled by the picosecond laser, but still there may be 20 to 30% of them are unsatisfactory. So in this way, we may need to choose other methods like fractional laser, peeling, a whitening cream, or tune down a little bit of your picosecond laser fluence in order to achieve the goal. So yeah, this is.
Okay, so multimodality is the best answer, I think. Okay, thank you. So now we're moving on for Dr. Reiva. This one is for you. Is it necessary to give antioxidant supplement before or after pickle laser treatment for better result?
Yeah, it's maybe it's a lot of the study about the antioxidant for the skin. Yeah, some is have some has a good result and correlate with the improvement of the skin, and some don't say that like that. Yeah, so it's depend to the quality of the skin, to the disease too. I think I will give the antioxidant to the patient that have a maybe aging skin or maybe other comorbidity like a diabetes, and also the age, yeah, the old one, that then not for the younger and the good condition of the skin. Yeah, it's like additional. It's good, but it's better if you can eat the natural products. Yeah, maybe like a fruit or the vegetables. Then only the antioxidant and the pills. I think like that. But it's not a fault to give it, but that's not unnecessary too, I think.
Okay, thank you very much, Dr. Reiva. And I think I see a lot of common question asking about fractional plasma. Maybe Dr. Sky Wong, you can explain again about fractional plasma and LIOB, because we have like 3 to 4 questions that asking about LIOB and the plasma fractional ablation. Maybe you can explain again.
Yes, let me explain it. And may I actually share the screen with you all? That, wait a minute. So everybody can see the screen, isn't it? And from the LIOB, it is actually a concentration of the fractional, the picosecond laser, which is, you know, the picosecond laser is already high powered. And when it is focused to a specific point, the energy will be upgraded to 2 to 3 times more. And then because of this very high energy, that will cause the molecule denature and results in electron cloud. The electron cloud will expand and result in a vacuum phenomenon. And then it will actually simply make a hole inside your dermal layer. And then with that hole, it will be some exudates going inside together with the PLP, the platelets, the fibroblasts, so that all of these kind of things will be mixed together in that pool. And then there will be a new collagenesis formation and some growth going into that small spot. And this small spot will be a concentration of all the factors to regenerate the collagen, okay? And so, as a result of this, it will result in a very good rejuvenation. And secondly, it is the plasma formation. So we have to talk about the plasma formation first, in which that for the plasma, when there is a very high energy light rate is going through the air and the skin interface, it becomes deflected, reflected, and then all in all, it becomes very unstable. When there is instability achieved, then they will result in plasma formation. And this plasma formation will be a ablative energy, so that it will ablate and resurface the skin. And when we use the focusing lens in an arrayed manner, that is, we are having the focusing point in a very orderly 120 and by 120 array, so that it will be just like a fractional laser. And this kind of fractional ablation, the ablation of the skin will be under a very well controlled manner. Everything is under control, then it will be actually healing very quickly and to our estimation. And then in this way, it will resurface our skin in a controlled manner. Therefore, with the MLA, it is not only able to get the new collagen formation, but also a controlled resurfacing of superficial skin.
Okay. Thank you very much, Dr. Sky Wong. I think it's explaining for the three questions. And now we are moving on, still with Dr. Wong, because I think it's kind of related. So in your experience, is Pickle Laser good for rolling scar? How is it compared with no core subcision? Thank you.
Yeah. Well, actually, for the three types of the atrophic scar, be it the ice break, the roll edge, and also the boss scar, the roll edge responds the best because it has no stepping. Okay, no stepping on the shoulders of the scar. And so with that, when we do the LIO, we do the MLA and picosecond laser, there will be LIOB. The LIOB will lay down the new collagens underneath the atrophic part of the scar. This is the thinnest part of scar. So it will actually pump up the thickness of the dermal layer, just like the subcision. That we do the subcision, we leave the scar underneath, and then we inject some of the hyaluronic acid. Actually, similar, but we are not injecting the hyaluronic acid. We are injecting the patient's own collagen. So that is how I take the term and convert it into the LLB. It is not actually really a subcision, but it has a similar concept of subcision, okay? And secondly, we can also have the higher energy to ablate the surfaces of the skin and results in a better smoothing of the bumpy skin of the atrophic scar. And therefore, the roll edge scar is perfectly managed by the picosecond laser. While for the boss scar, it's also quite well managed. However, for the ice break, it is not very well managed because it's so deep. Therefore, we may need to do some surgical procedure. We need to do a cross peel. We may need to do a lot of other things. And actually, for the picosecond laser can help, but it is not to the very perfect condition. You can see that from here, my presentation, that for a patient really have a multiple problem of atrophic scar. Let me share the screen with you. So you can see from here, can we see that? We can see that, right?
Yes.
From this patient, you can see the skin is actually having some rolled edge and also ice break, okay? This is the rolled edge. There's some spot boss scar and also ice break. And when we have done a series of treatment of picosecond laser, you can see that the rolled edge and also boss scar has improved quite a lot, right? However, for the ice break, it's still not very well managed. And in this juncture, we may need to do some cross peel in order to make the result even more perfect.
Okay, thank you very much, Dr. Sky Wong. So now we are continuing, and I think Dr. Reiva can help us to answer this one. How do you combine 1064 and 532 to treat benign pigmented lesion? Is it together in one-time treatment or alternating in the next session?
For the benign, so which one?
It's in the chat box.
The chat box.
Yeah, can you combine 1064 and 532 to treat benign pigmented lesion? Is it in one time or alternating?
Okay, so it's depend of the lesion, but for the benign, I think this is for the pigmentation lesion, right? So
Right.
it's depend of the diagnosis and also the melanin. Yeah, the melanin, the layer is it at the epidermal or at the dermal? So for the epidermal, we choose the 532, such as like freckles and also so freckles and and for the 1064, the good result for the nevus of Ota, something like that, and also quite a little bit for the melasma, like that. So in one patient, we usually not have just one epidermal, one layer of the melanin. So we can combine it. We can see for the maybe deeper melanin, it's for the like a blue or the black spots there, or like a shadow. So we choose 1064, and then for the epidermal, there's like a brown, maybe it's a little bit quite a different in the Asian skin. Like in Indonesia, we have a lot of people that have a 5 Sp.KK skin type 5, yeah. So based not like at a brown skin, and so the lesion like a brown or black or something like that, it's quite difficult. But for me, if you don't, if you're confused about the layer and also not sure about it, for the safer, we can choose the 1064, and we can try only for a few spots to the epidermal lesion.
Okay, but you do it in one session, Dr. Reiva?
One session, yes, but different sites.
Oh, different sites. Okay, so Dr. Sky, do you have additional answer to this?
Well, I think Dr. Reiva is very experienced, is actually doing exactly the things that I do. And for me, because PicoSecond laser is very, very gentle, and therefore we can actually afford to use all the wavelengths like the 532, 1064, 670, and together with MLA at one sessions. And actually, you know that for the skin problem in your face, is multiplanary. A lot of different problems. Maybe pigments are a norm in horizontal in one hand, and then some freckles on the nose, and some on the cheek there will be melasma. So for different area, we'll use different wavelengths for different purpose. So I think that yes, I will do all the wavelengths if it is indicated.
If it's happening in one in the same place, so which one will you go first with? 1064 first or 532 first?
Well, actually, I would like to, for me, it really depends on the condition. For example, if the usually my practice is that I will do the spot treatment first. That is, for example, the patient have the freckles very simply, and we'll do the 532, 670 spot treatment on that first, and then we'll do the tuning for the base for 10/670. If it is for the horizontal, I will also do the spot treatment first, but I will do the shorter wavelength first. For example, the 532 or 670, and then because the penetration of 1064 is longer, so it is less likely to be affected by the frosting or all sorts of reactions in the most superficial parts of our skin. So I would do the 1064 at high power, for example, 5 millimeter, 2.5 fluence onto the same spot. And then I will do the tuning pulse, picosecond tuning over the face, something like that. So this is my approach. But sometimes if the patient is having very delicate skin, I may actually only do the tuning first, because they may have already irritated after this kind of gentle procedure. If this kind of toning is not being irritated by my first layers of procedure, then I may go for some higher power spot treatment for them. So it really depends, but in general, I will do a shorter wavelength first, and then spot treatment at the first layer, and then do tuning at the end of the treatment. Yeah.
Okay, thank you. We still have some more questions. Okay, I think this one is for Dr.Sky Wong. Actually, the question is quite long. So it's about the ribbon phenomenon of melasma due to the use of hydroquinone cream. How many times have you experienced until it gives improvement for the ribbon phenomenon? Yeah.
Yeah, well, it is very, very difficult for the melting type of the ribbon phenomenon, periorbital melasma. It is what I termed the light unstable, recalcitrant types of melasma. If you use the picosecond laser, you have to use it very gently, never go high on the energy, and quite a lot of time. You may need to use a lot of adjuvant treatment. And in this case, I quite like using the isotretinoin or the tretinoin. Tretinoin is for the applications locally, like the adaparin. While in more severe resistant case, I will actually choose for oral isotretinoin as well, together with transamine. With these two, you will actually stabilize your skin pigmentation. After stabilizing it, then and only then you go for destructive approach for the melanin. Then you will have a better result. If you are going for the PicoSecond laser, higher energy, or all sorts of irritating treatment at the first place, what you get is the irritation, the inflammation. But at that time, your skin is not yet stabilized. Therefore, you may have a higher risk of the worsening of melasma or hyperpigmentation. And that's how what I mentioned in the presentation, that even though a small minor step, this is going wrong, you will screw up all the things. Therefore, the sequence is very important. You may need to use a lot of adjuvant treatment, pre-treat the patients, pre-condition the patients first before we go for PicoSecond laser. Okay, so when we stabilize the skin and do the PicoSecond laser, usually for 3 times of treatment, you can see the results.
Okay, Dr. Reiva, do you have any experience also with the ribbon phenomenon?
No, but yeah, it's it's very difficult to treat. So the lower energy is better, I think. Yeah, and it takes a long time, and the patient and have need the patience from the patient and also from the doctor too. Yeah.
Okay, then we will continue. I think this one is for Dr. Reiva because you're doing tattoo. So is it true that more dense black ink should be treated with Nanosecond first, and then after that with Pickle Laser afterwards? Do you have any opinion on this?
I think so. Because that very dense, very thick of the melanin, yeah, we have to destroy it with like a nanosecond laser, and then after it's maybe like fragmented, and then we do the second session with the picosecond laser. Yeah, that's true. So that's why in my case for the very black ink, I want to try just for the. I have another laser with the key switch NDX, but I think I want to try for this patient, so it's not really good for the very dense and black ink like that. Maybe Dr. Wong, do you have experience for like this case? Yeah, do you agree about we have to use the key switch first, Amel?
Yeah, Dr. Sky Wong, do you have any opinion on this also? Do you have you ever do tattoo with PicoSecond laser?
Yeah, I totally agree with Dr. Reiva, because for the tattoo, especially for the aged tattoo for a long time, they condense together to make up a very big rock. And in this way, if you are going for the PicoSecond laser, by photomechanical effect, yes, you can still do it, but it's less effective. And in big rock, you can actually use the heat energy to melt it down. That is the photothermolytic phenomenon. And that is how the Q-switch laser is being applied. And however, there is one point that we need to consider is that if the patient's skin is very delicate, they don't want to really have very nasty blistering formation. They tell you, oh, doctor, please be gentle. So at this kind of particular patient, we may still go for picosecond laser. Okay, so you may need 2 to 3 more times of the treatment of picosecond laser for the same result. But whether it's because the patients estimate the expectations like this. But if in the first 3 times, especially for very dense, intense, dark ink picosecond, I mean the tattoo, and is for age tattoo. For the first 3 times, I may actually try to use nano laser as Dr.Reiva has said, and therefore it really depends on case by case. So what we should have a console of laser that has the both Q switch and also the picosecond laser, so that it is more flexible for us. So actually, I think that's I've been using picosecond laser for really a long time. Actually, 7 years ago, I used my first console, and that is an 755 nanometer. It's only pico, but I think that the dexterity and flexibility of that console is not as good as the combined skill switch and the picosecond laser. That we can actually have more room to adjust our technique and flexibility of the application. So that's how some of the manufacturer like the Qtera can provide both the Q switch and picosecond laser for the better treatment, optimal outcome. Yeah.
Okay, thank you very much, Dr.Sky and Dr.Reiva for the answer. So I have this special question from Dr. Wong. I think it's for Dr. Sky Wong. How do you differentiate so many types of melasma? Is it a standard classification?
Oh, Professor, did you have any comment first? Because I learned from you.
Let me see if I... Professor Warapong, do you want to talk? Let me... I will allow you to talk if you want to.
Hi. Hi, Sky and everybody. So I this is first time I heard about the classification of melasma that you mentioned, because the only classification that I heard about is to classify it as epidermal types, dermal types, and mixed type by using wood lamp. And to me, even that standard classification, I see all melasma are the same. The same in my sense is we never be able to cure it, no matter how good the laser or how good the oral tranexamic acid is. So to me, I think it's no use to try to classify type of melasma, because melasma is melasma.
Yeah. For me, I do agree with Dr. Wolfong, but if it is a geographical one, it's very actually all the melasma has to be aware of the disease mechanism. It is a kind of metabolic problem, skin structure problem, because the skin structure is being destroyed. Therefore, there will be like the melanin incontinence, pendulum, melanocytes, and a lot of macrophages, something like that. So we will also consider whether or not there is a vasculopathic or there is any inflammatory condition. If it is a very calm melasma, then of course we can do the toning and lots of simple things that may have the improvement. if the patient has got the vasculopathic, for example, they have the vascular problem, we need to also use a vascular laser to control the condition before we really have the very effective treatment on the melasma, because the VEGF is quite well demonstrated by some of the research that it may be related to the hyperactivity of the melasma. And then it is the inflammation. If there is inflammation, then we may need to use to calm down the skin by using all sorts of the anti-inflammatory treatment, or even using the, there is an audience mentioned, we may need to also use antioxidants, because there is a lot of free radicals will increase the inflammatory index of skin, and this will also causes the melasma to be very, very bad in the response to all sorts of treatment. And very importantly, we need to differentiate between the hyper and hypopigmentation mixture of melasma to get, or the light and stable melasma together with the light stable melasma. If it is in the way that you already have the hypopigmentation, like in the mottled dyschromia, or in the cases of the ribboned light melasma, at that time, if you do the laser at a little bit higher fluence, then you will invite trouble. Therefore, we need to stabilize the skin and use all sorts of preparation that I have mentioned before we go for the PicoSecond laser. And the same PicoSecond laser fluence is just like Dr.Reiva has mentioned, should be lower in fluence, or even those, or even we need to use other modality of treatment like the fractional lasers, like the Professor Rashima has mentioned in her study. So it is very difficult to classify the melasma in a very, very systemic way, but we are actually seeing the light of the classification. We try to classify and guide our treatment. For example, if this is not a very widespread melasma, only a small area of melasma, we may change our approach by using the destructive approach. That means that you can use very high energy like 1064, 2.5 joule per cm square fluence at 5 mm spot size to blast it away. And then you may invite some of the hypopigmentation at that time, but with time, because the area is small, then it will recover itself. And this is one of the treatment that approach that we can use, apply in the cases of the isolated islands. That is a lot of a small area of melasma, not going to be very well managed by the general toning, then we can go for it.
How is it, Dr. Warapong?
Yes, I just have 2 or 3 comments about melasma. This is just my personal opinion. Number 1 comment is I never use laser as the first line of treatment for melasma. And number 2, no matter what kind of melasma, if I were to use laser, I will be use very gentle or conservative approach. I never use high fluence or high energy or multiple passes because it tends to create a rebound hyperpigmentation or post-inflammatory hyperpigmentation. And my last comment is, I am one of a person who don't believe in vasculopathic or the vascular genesis of melasma. The main reason is we do have a vascular specific laser that can specifically destroy cutaneous vessel. And this concept has been now for almost 10 years or over 10 years. So I believe many doctors has tried to use even pulse dye laser, copper bromide, or any vascular specific laser to treat the so-called vasculopathy first. If it really works, how come there is no report that we can permanently cure melasma? Why we have to still talking about the melasma? If the vasculopathy is true, this is just my comment.
Yes, I think so. And I think that it may not be really that related. And from my personal point of view is that it may not really be due to the vascular component that causes melasma, but it is because the redness of the vascular component discolorization of our skin together with the melasma blindness discolorization, the red plus brown adding together will make the pigmentation more contrast out. And that's why if we actually remove the vascular components of our face, that will make the pigmentation less obvious already. And at the same time, after removing the vascular component, and then we use the low fluence PicoSecond laser, just like Professor Wong has mentioned, then it will be dimmed down a little bit. So both of the color fades out, and then the outcome of the so-called vasculopathic melasma will be having a better outcome. And I also agree with the Professor Wong, it may not be really that related. It's just like the contrast of colors that we tackle separately to obtain a better result. Yeah, this is right.
So, Professor Warapong, any additional knowledge for us today?
No, that I just would like to join my friends. That's all.
Thank you very much, Professor.
You're welcome.
Thank you, Professor.
Nice. Yeah, it's nice to have you here. It's like special guest for us today. Thank you. So now I think I will have to choose maybe one or two questions more. So this one is for Dr.Sky Wong. Is there any probability of recurrence after a successful pickle laser treatment? And when does the recurrence occur?
Well, it really depends on what kind of the pigmentation you have. For example, for the freckles, if you have very good sun screenings and avoidance of the UV rate, usually you are quite well with the treatment result for really a long time. For me, I love a lot of outdoor activity. 7 years ago, I've got my PicoSecond laser done, and then my freckles is all gone. And it's not coming back because I'm very obedient to the sun screening, okay? For the anorm Horace macule, the results, the outcome is very linear, excellent. And then they seems to be very difficult to return. So when you see the Horace macule, wonderful things that you just ask them to do the PicoSecond laser. And for the melasma, very different, very difficult. Because this is not really a problem of the pigment. It's a problem of the mixture of the skin structure problem, hormonal and metabolic problem, inflammatory problem, all sort of things. So that if it's easy to recur. And then you have to also have a good discussion with your patients that your expectations should not be tuned too high, okay? Because always you may not have a very good outcome result. Usually you may get around about 30% to 70% of improvement. Whether or not you are on the 30% side or 70% side, it really depends on your skin response. And sometimes some people will actually get no response at all. So we need to really discuss with patient and cannot promise patient a lot.
Okay, Dr. Reiva, have you ever experienced any recurrence after PicoSecond laser?
Recurrent, yes, of course, because for the treat the perfect or the resolution 100 resolution, we have to do a serial series of for the laser treatment, and then after that we have to protect still with a sunscreen like that, and also tretinoin cream, and also maybe a Glickman and hydroquinone. But with my experience, if the patient is maintenance their skin condition, maybe not too quick to recurrence. Yeah, maybe about 1 year after that, or as far as like 6 months, they have little spots, but it's okay, disappear with the hydroquinone like that. But maybe 1 year or more, depend on the maintenance of the skin.
Okay, thank you very much. I think this will be one last question for Dr. Sky Wong, because this is talking about the abnorm that you use this 670. So what is your endpoint treatment for abnorm with 670?
Well, actually, for the PicoSecond laser, it is very interesting things, especially, for example, in the past, traditionally, we use this Q switch, right? Using the 532 or 755 nanometer, what we are actually going for, the endpoint, the frosting, right? But if it is in our PicoSecond laser era, when we treat the freckles, we don't aim at any endpoint, no frosting at all. You don't need to really have the frosting, and you really need to believe or have the trust on your machine. Okay, it's the same for anorm, using the 670 for the for your anorm or Horace macule, but in a way that if you are actually patient enough, usually after shooting your 670 onto the skin, after 1 to 2 minutes, there may be a little bit of delayed erythema, and that's all you need to get. Okay, you don't expect any frosting, you don't expect on any petechiae for 670, and you only aim at seeing a little bit of delayed erythema. With the delayed erythema, it is 670 is treating the superficial and deep part of anorm. And remember, anorm or Horace macule, it is pathologically under a microscope. It is a deep down digastric abnormal melanocytes deep-seated in the dermal layer. Therefore, there is also a deep part. For the deep part, you also need to use 1064. When you use 1064, you need to use a medium spot size like 5 millimeter, and then your fluence for the 750 picosecond laser is around about 2.2 to 2.5 joule per cm square. And then with the 1064, there will be some petechiae, but the petechiae is not induced by the 670. But for your treatment, you need to combine the 670 together with 1064. Therefore, when you do it, you do the 670 first, and then wait for a little bit of delayed erythema, and then you shoot on the high power 1064, and results in a little bit of the petechiae. And it's very interesting that because in the first time of treatment, the melanin pigmentation intensity is high. It's very dark color, so that they absorb more energy, so the petechiae is more severe. But in the later time counting, round about the third time or fourth time, the pigmentation is already very dim. And even though you use higher energy of 1064, it would not induce so severe a petechiae, or just a tiny bit of erythema, something like that. So the endpoint is really different from different wavelengths, different severity of the anorm, or at which time that you do the anorm treatment.
Okay, well, actually in Indonesia, we don't have 670. If we only have 1064, how can we maximize the result?
Well, I've mentioned for 1064, it is going for the medium and deep part of the Horace macule and the fluence and all the setting I've mentioned before. To reiterate that we use higher fluence like 2.2 to 2.5 joule per cm square, around about 4 to 6, or usually I use 5 millimeter for the treatment 1064. And you can also check with my publication in JAMA. You just search JAMA, anorm, and then Sky Wong, something like that. You can get the paper. And don't forget about the superficial part, because for the Horace macule, there will also some of the entity will have the superficial part. Then you may need to use a little bit of the 532. Okay, but for 532 will induce more ripple result. It's just that there is some smoky-based hyperpigmentation after first 2-3 times of treatment. Don't worry about it. It has to happen in the Asian skin. Don't panic. And then even though you have such kind of smoky base, just tell the patient it will go away soon. Okay, so don't forget to use the 532 at the first field treatment when there is the superficial component of Hori's macula, and that is the approach.
Okay, thank you, Dr. Sky Wong. Dr. Reiva, I see in your presentation you also have the same experience. Can you tell us a little bit what is the endpoint when you are doing the abnorm or Hori?
The endpoint is like a slight purpura, yeah, so slight purpura, but not to become erosion. And then just it's better if we shoot just one time and then we wait for several seconds or maybe several minutes, because the purpura PiCo is will appear just not that after we shoot, yeah. And so just be patient, shoot, especially at the first shoot, yeah, and then you shoot first and then wait for several seconds, several minutes, and then it's become the purpura or maybe the PiCo. After that, we can stay at the energy, or maybe we can decrease it. Yeah.
Okay, so now it's 5 minutes to 9 in here and 5 minutes to 10 in Dr. Sky Wong's place. Thank you very much, Dr. Sky Wong and Dr. Reiva, for your time, and thank you for all the participants today. So before we end the session, I would like to have like a photo together with Dr. Sky Wong and Dr. Reiva. So I will do the screenshot. Better get ready.
Gosh.
Okay, Dr. Reiva, you ready? Okay, 1, 2, 3. Okay, once more for confirmation. Oh, wait for a second. I think I should add Emily. Yeah, to be together with us. Hi, Emily. So this is, okay, I will do screenshot one more. 1, 2, 3. Okay, so thank you very much, everyone. Thank you, Emily from Qtera. Thank you, Dr. Sky Wong, and thank you, Dr. Reiva. Thank you to all the participants. I wish you all healthy life and safe life from COVID-19. I hope we can meet soon in the real life, very, very soon. So yeah, have a good night, and thank you, everyone, for joining today.
Thank you.
Goodbye. Thank you.
Bye.
Bye.
Bye. Take care all. Thank you.
Thank you.